Good evening, everyone. Shall we begin now?
Hello, Doctor.
Yes,
We can start. Over
we
to
can
you.
start.
Yes.
Before Dr. Nzamu shares the presentation, it seems like she's having some challenges. Good evening, everyone. Welcome to today's session. The topic is palliative care in childhood cancer. My name is Dr. Valerie Erulu. I'm a medical officer working in the pain and palliative unit in Kenyatta. I would like to take this opportunity to introduce our speaker for this evening, Dr. Irene Zamu. So, Dr. Irene Zamu is a pediatric hematologist, oncologist at the Kenyatta National Hospital, where she heads the pediatric hemato-oncology unit. She holds a Bachelor of Medicine and Bachelor of Surgery degree and a master's degree in pediatrics and child health, both from the University of Nairobi. She completed her pediatric hematology oncology fellowship training at Makerere University in Kampala in collaboration with Baylor College of Medicine and Texas Children's Cancer and Hematology Center in Houston, Texas. So her passion for children with cancers and blood diseases came to life during her residency training in the Kenyatta National Hospital, where most patients presented late with advanced disease, leading to poor childhood cancer outcomes. Her goal is to improve childhood cancer care in Kenya by advocating for early referral for diagnosis and treatment. She aims to offer affordable, evidence based care for Kenyan children, particularly in the public sector, despite the resource constraints. She is passionate about teaching and mentorship, teaching pediatric hematology, oncology topics at the University of Nairobi's College of Health Sciences. And she is the treasurer for the Kenya Society of Hematologists and Oncologists, KESHO, and a member of several professional bodies, including International Society of Pediatric Oncology, SIOP, where she serves in several committees, and Global Hematology Oncology Pediatric Excellence, that is Global Hope. So, welcome, Dr. Zamu.
Can you hear me now? Hello?
We can hear you, Doc. We can hear you, Doc. Please go ahead.
I can't hear the meeting. Can you hear me now?
Yes, we can, Dr. We can hear you.
I don't hear at all. Hello?
Dr. We can hear you.
Yeah, I can't hear you. Because me, I was thinking maybe meeting haijaanza, so I was just waiting for it to start. Yeah. Sikusikia anything. Hello, can you hear me now?
Yes, we can hear you, Dr.
Oh, I am so sorry. I'm extremely sorry. You know where I'm connecting from. Sorry, colleagues, and good evening. And apologies for that. My name is Irene. I'm a pediatrician, pediatric hemato-oncologist. I work at Kehpca National Hospital, and I'm truly sorry, got caught up, and my slides are being shared for me. So today we are going to have a conversation about palliative care in childhood cancer. And we shall just proceed as the slides are continuing. And as we are looking at a pediatric palliative care, we'll just look at an introduction, have a brief overview on the childhood cancer, then look at effective pediatric palliative care, what the components are. Then we have to talk about end-of-life care, and we shall share some resources and references for each of us to go and look at when we go home. And so when we define pediatric palliative care, it's an interdisciplinary collaboration. So we work together to improve the quality of life for the children with the life-threatening and also the life-limiting conditions, and also together with their families. And it's good for us to note that it begins at diagnosis, and it focuses on both preventing and relieving suffering. So no matter the stage of disease, even when the children come in to us when they are stage 4, stage 5, we still have to think about how to maximize on their joy of life and how to relieve their suffering. And in the pediatric palliative care, we are looking at addressing the physical, the psychosocial, the spiritual needs of this child and also together with the family. So we are looking at those 4 domains in the next slide on pediatric palliative care. The key domains will be the physical, is this cancer that has brought them to us, and the physical symptoms that we are treating. And then the center is where the child is, but all around you can see we are looking at the spiritual aspect, the psychosocial aspects of the care of this child, and also together with the family. And that's what all of us will be doing together, even as we support these children. So now, talking about childhood cancer, it is rare among the childhood diseases, but as rare as it is, it's also a leading cause of death. So let's remember, even if we are told it's 2 to 5% of all the malignant tumors, and there's a lot of focus on the adult cancers, which are so many, each year about 400,000 children will develop cancer. And when a child is having cancer, the whole family is sick. And so as we are thinking as palliative care practitioners and people who want to support these children, we have to think of this child and the whole family. Only 10% have genetic factors that predispose them. And if you look at the incidence data being displayed, we can tell that the commonest one has been acute lymphoblastic leukemia. Ever since those old years, the trend has not changed. Even now, we are seeing acute lymphoblastic leukemia being the commonest childhood cancer. Now, our brain and CNS tumors should be next. This is globally, but here we are missing a lot of the brain tumors, again, because of misdiagnosis. Sometimes they are being treated out there as meningitis, cerebral malaria, typhoid, and we are not really thinking about it, so we are missing them. After leukemia, we are followed by lymphomas, are very common, even here in Kehpca and in the other centers treating children with cancer. In terms of the solid tumors, for us, the Wilms tumors are the commonest, commoner than neuroblastoma, and then also the soft tissue tumors, that is rhabdomyosarcoma. But as we look at this data, we are going to see next that there is a big disparity in terms of care, no, in terms of survival. It's like for a child with cancer to survive, it just depends on where you've been born. And so if you've been born here in the low and middle income countries, where more than 80% of the disease burden is, our survival is less than 30%, sometimes 20, 25%. And in the high income countries, where they only have like 20% of the childhood cancer burden, here again, their survival rates are above 80%, which means childhood cancer is actually curable. We can be able to treat these children for cure, and we can be able to achieve those cure rates. But right now, we are at a bad place as a country, as colleagues, as low and middle income countries, and we are trying to bridge that gap for disparity. We are hoping to achieve the WHO, the Global Initiative for Childhood Cancer Initiative. We are trying to look at 60% by the year 2030. Now we are still very far. And our children are dying because we are not diagnosing them early, or we are misdiagnosing. The time they get to us, it's often very late. They're just coming in with stage 4, stage 5 disease. And they are coming with just for palliative care most of the times. We are also having obstacles in access to care, access to specialists, even money to do the diagnostic workups is a challenge. Treatment abandonment has also been an issue we are facing. Once the child starts getting a little bit better, most of the parents will not even see the need to continue and finish the protocol for the chemotherapy. And so we are losing a lot of our children at abandonment. Now they come back later when the child is dying. And we're also having some deaths because of treatment toxicity. This data just shows us the global disease burden and also the global CAN data, just emphasizing the fact of the discrepancy between those in the high income countries and us where we are. But we have to keep trying to aim for cure where we are, and where we are not able to achieve cure for our children with cancer, we hope to palliate them well. And so we have to talk about how to suspect the early warning signs of childhood cancer. Remember, each of us here interacts with children, whether we are parents or we have nephews, nieces, at church, in the community. Everywhere you're seeing a child, you and I, we just need to suspect, because childhood cancer presents like any other of these common childhood diseases. But we have this acronym, it's called child cancer, going down. It just reminds us what to suspect so that we can send them early for early diagnosis and early treatments. Remembering childhood cancer is really not preventable per se, but it's curable if they come early. And the first thing we can see, any continued unexplained weight loss, children must gain weight. They're supposed to be growing and gaining weight. So the weight loss is a red flag. Headache is not normal in children. When we see headache, please, let's just have it in our minds, especially with early morning vomiting. Are we missing a brain tumor? When we have increased pain in the bones and the joints, why would a child be having all these joint pains and bone pains? It's easy to quickly suspect. It's even better to investigate and rule it out and find it wasn't childhood cancer than to ignore and then find out later it was the one, and by then the disease is very advanced. Any lump or swellings in the body, the D here usually talks about the bruising, if they have anything on the skin, purplish lesions or blood coming from anywhere, could be leukemia. The C is for constant infections, and for us who are here, I know we've been culprits and victims where children come and we're giving antibiotics for infections over and over again, changing from first line to second line, even to injectable antibiotics. But we are not suspecting at the back of our minds, this could actually be a leukemia. The whitish pupil, again for retinoblastoma, issues of persistent nausea, vomiting. This C for constant tiredness. Children are supposed to be active and playful. A child is not just supposed to be feeling dull and disinterested and tired or feeling lazy. Sometimes children would even be beaten in school or even at home, and the parent is saying this child has just been lazy, of course doesn't want to do anything nowadays, but the child is just tired, fatigued. Could be anemia, could be a leukemia that is hiding. Visual changes, again, anything to do with the eyes there, and then recurrent fevers of unknown origin. If you look at all these things, it could be any other childhood disease, but it's a red flag for suspicion, early warning signs. All we want is to suspect, then send for some basic investigations to rule out so that we are not missing, and if it's childhood cancer, we get it early. So when you get them, we investigate broadly. This was just a broad overview, not a specific malignancy we are talking about. So depending on what now we are suspecting at that time, we can do the routine labs that are available in all our hospitals, even the health centers, where we can do the basics like the hemogram, sometimes a peripheral film, the UECs, and then you can also send them for more advanced laboratory tests in the next referral hospitals. Imaging, all the scanning, even from basic chest x-ray can show you a mass in the chest of a child, or even abdominal ultrasound. Even if we don't have CT scans and PET scans and MRI, all these things can help us to make a diagnosis. Tissue is very important for histopathology in confirming the diagnosis. And immunophenotyping, this is both flow cytometry or immunohistochemistry, depending on what cancer you are suspecting. When you do the bone marrows, they can also be sent for flow cytometry. And where it's available and affordable, we can also do cytogenetics and molecular studies. So now we've investigated, we've seen it is childhood cancer. How we approach it, we have to look at the oncologic emergencies, the things that are going to kill this child very quickly. And we need to quickly step in and manage them. Here you're talking about that child who has now come to you as a nurse or as a doctor, the clinician, the health worker, where you are, the physiotherapist, and they're having difficulty breathing or they're swelling around the neck. Maybe they're having these mediastinal masses around the chest with those superior mediastinal syndromes or superior vena cava things, masses that are really obstructing the airway, even things like fever with very low white cell count, that's febrile neutropenia. That is still an oncologic emergency. We need to sort it. Then we have to stage our children. For every cancer, it's disease specific. Each of these childhood cancers has a staging system and also a risk stratification system. Because the ones who are low risk, you want to give them lesser chemotherapy in terms of the drugs involved, the number of drugs, and even some for a shorter duration. But the ones who are high risk, again, you don't want to undertreat the ones who are high risk, and you don't want to overtreat the ones who are low risk and expose them to a lot of unnecessary side effects. At diagnosis is where we now do our diagnostic counseling, we do our family conferences, and this is a point where now our pediatric palliative care team is on board with us. So we start working this journey together from diagnosis. We talk about our goals of care. In childhood cancer space, we're either talking about the goals being cure. So we are doing aggressive treatments and everything possible to get the child to cure. And the goals can also be palliative, knowing that with the limitations we have and the advancement of the disease we have, we are not being able to achieve cure. So the goal becomes palliative, but we start with palliative care from diagnosis. And remember, we said that our survival rates are about 30%, like now in our country overall, and in the low middle income countries. So it tells us we are having a lot of mortality. So many of our children, as we improve care and get better survival, a bigger number of our children who are presenting very late to the treatment facilities tend to take the path for palliative. And that's why we really need the palliative practitioners and all of us to work together. And then the treatment is usually multidisciplinary, whereby now our modalities can be chemotherapy, can be surgery, radiotherapy, even immunotherapy we are doing, targeted therapies for those ones that have targetable lesions, and then even bone marrow transplant, solid organ transplants. Now this is just disease specific, depending on which childhood cancer we are dealing with. Now, even after we have treated this child, we still have another battle ahead because of survivorship. Remember, now we have all these late effects that these children are facing, and palliative care is truly involved. And you know, if you look at these effects, in fact, the first one for the delayed cognitive development, and these children are having learning disabilities. Some of them had radiotherapy to the brain, and some of the chemotherapy agents we give are so toxic. And so when this child now survives and integrates back to community, we don't want people to put pressure on our children. We don't want the teachers and the academic system to push our children. We just want them to be the best version that they can be, knowing the difficult cancer journey they've been through. And so they need a lot of support going across. And we've had to talk to schools. We've had to write letters to institutions to allow our survivors be the best they can without having to push them to that extra limit. Growth is a problem. Sometimes they have hearing and speech defects. Infertility is a major one because now we are getting more and more survivors of childhood cancer. Issues of nerve damage. Our children with bone tumors, the osteosarcomas are amputated, even the Ewing sarcomas, and they get all those phantom limbs and nerve issues and nerve pain. Some develop even secondary malignancies and organ effects like heart failure or cardiomyopathies. So you can see this journey doesn't even end after treatment. Even into survivorship, we still have to work together with our palliative care teams. Now, there's a disconnect. And that's why we are having this conversation today. In pediatric oncology and pediatric palliative care, we must work together. And we usually work together from beginning to the end. But what has been happening is that the focus has been so much medically on the diagnosis and treatment. Doctors and clinicians and nurses and everyone we want to diagnose, do a myriad of tests, stage, stratify, get a protocol and treat. That's okay, but that should not be the focus. The focus should be on the holistic care because that diagnosis and treatment is only just one aspect. And many children now dying of cancer, they really suffer. And a lot of times we really would wish that they would have access to pediatric palliative care practitioners or even people like you and me who are now getting into these conversations and have even short courses and forums of how to support these children. They don't have information. No one wants to talk to these children, especially the older ones, because people don't want to be asked questions by a child and they cannot answer. So they die sometimes feeling very lonely, and most of them are dying in hospital. Again, if we were able to meet the gap that we need for palliative care in childhood cancer, majority of our children maybe would not be dying in hospital. The parents are the decision makers. Again, most of us ignore the children when it comes to decision making. And yet that child is actually the patient. The sickness belongs to this particular child. No matter their age, there are those age appropriate ways of communicating. So we need to think about how to involve them. And our survivorship programming in this country, we are running survivor clinics in Kehpca, even in MTRH and other hospitals, but it's not really structured. So this disconnect is what now we are trying to bring ourselves together and work together as one team, aiming to offer better palliative services to our children. We're integrating the approach as shown in this slide. So from the time we diagnose, the way that arrow is moving across, from the time we start, we are managing this disease, whether we are going towards cure and survivorship, or whether we are going on a downward trend towards end of life care, because this child has come very late and all we can do is just offer symptom control. Either way, across this journey, whether we are rehabilitating the children, we need to integrate ourselves together and understand that in childhood cancer space, you and me, everyone, the palliative team and the treating physicians, we all have to walk this journey together, even until bereavement is still part of it. So who is part of the team? The team, we said, is multidisciplinary. So nobody should or can say that me alone, I am enough, or I'm offering palliative care to the children with cancer by myself. We need each other. If you look across on this slide, you can see everyone is on it, everyone. And we recognize our palliative trained nurses and doctors because those are our palliative care practitioners and we really need them. But again, we have everyone else, the child life specialists, our spiritual leaders, our psychologists and counselors, nutritionists, even volunteers, social workers, occupational therapy, anyone, even the community volunteers. And let's always remember to involve the child and the family so that as they walk this journey, they are fully supported. And the next diagram, I think here, it was just showing us that from where the child and the family is sitting, and the support next is just around the community because they are coming from a community and we're able to support them there. Then next we look at what primary healthcare services they can access, and then now the specialized pediatric palliative care services that they require, recognizing that we are really stretched. The need is so much, but the providers for the pediatric palliative care are really few. So let us look at the components of effective pediatric palliative care. For us to say we are offering effective palliative care to our children with cancer, we need to remember, like I said, we need a team. So if you find yourself alone offering all aspects of pediatric palliative care, then you know something is not right. Then the issue about communication and building relationships. By the time you're caring for a child with cancer, you've walked a journey with this family, with the children, whether it's a short journey because the child just came in dying, or sometimes a very prolonged journey, but you need to build trust and relationships and open communication with these children and also their parents. We need to have coordination of care as a key component in terms of where is this child receiving their palliative care. The child has received cancer treatment, let's say in Kehpca or in MTRH. I'm talking a lot about the public sector. But again, can they go back down? We are having those networks where some of our children are now receiving pediatric palliative care in the county hospitals, and we are keeping the communication channels open with the persons involved there. And we continue supporting these children and the families across the journey. We need to also develop care plans based on our goals of care for these children, and we can do it together. Symptom management is very key, extremely important for our children with cancer because they really do suffer. And of course, end of life care is a very important component. So we are going to touch on just a few of those components. The first one being the medical decision making. And I know most of us who have logged in here are healthcare workers and mostly nurses and doctors and nutritionists, people who are involved. So when they make, and you're usually together in the ward round or in the discussions about these patients, when medical decisions are being made for these children, the issue of advanced care planning, this is something you need to raise, even yourself, when you're discussing with whichever consultant or with whichever persons you are with making decisions for this child. When the child now reaches that stage of deteriorating, and now we know they are heading the downward path, do they want to be intubated and be kept on mechanical ventilators? What exactly do they want? What are their wishes? And children are able to speak. I've learned over time because I really work a lot with children. They'll tell you what they want. The family also has their wishes. It's sort of a shared decision making. And this advanced care planning is really important. So that's when the child gets to that point, there's no confusion and there's no, there's no much frustration because it's really clear what is to be done and what they wanted to do. Initiating therapies. which may not even benefit the child and may even prolong the suffering of these children with cancer. Again, it's okay for us to have these conversations and caution each other and remind each other. Remember, most of the doctors or the people who are treating these cancers in children sometimes don't even have any palliative care training. And so people may talk about big things and big therapies that they want to give these children. But again, for you as a very important team member, it's in your position and it's in your role to caution and to ask, even as you discuss with the family, what is going to be the benefit of this? Surgery, yes, we give chemo, we give surgery in the palliative setting, even for those children we know are not going to achieve cure as per medical science. But again, if the child cannot eat, cannot breathe, cannot pass urine, they can go for all these colostomies. You can have the PEG tubes for feeding. Our children who are above 8 years of age, they are very conscious about how they look. They don't want to have tubes hanging out of their nose and everywhere in terms of NG tubes. So we can just have a nice gastrostomy, a tube hidden there under the stomach. The child can feed, but can also feel like they're looking nice, because that's part of making them feel good as they go through their treatment. And it's okay to caution and to discuss this with us as a team. Like we said, when people want to do big surgical procedures for a child with seriously metastatic disease, and you start wondering, to whose benefit are we having these major surgeries and how are they helping this child? And of course, there are those that get it when they're still in the uterus. So if you have a diagnosis that was made before birth, again, we need to plan early when the child is born, what exactly we are going to do. Now, the symptoms for our children who are dying of cancer or who are still on the journey for cure, but they are suffering with cancer, these are the major symptoms that we have to deal with. Pain, please, let's not allow our children to suffer pain. And I know palliative teams and palliative practitioners have been very much aggressive on this. We must assess pain. There are tools for assessing pain in children, even those who cannot speak, and we make sure they are comfortable. And look through all these symptoms, and there's actually medical management for each of these. There's actually a drug and there are dosages that you're able to give to address any of these distressing symptoms that the children may have, whether during their treatment or even at the point of death. So let's be on the lookout to just notice these symptoms, and if we see any of them, we address them appropriately. Apart from the medication, the non-pharmacological interventions, these ones I really love, because there's no injection being given, there's no medication. It's just coming and cuddling the children, giving them a massage. Where I work, we have 2 pediatric cancer wards. One is called Ward 3D in Kehpca, is the bigger one. It's really full. Oftentimes has an average of 65 to like 90 children with cancer, and Ward 1E is 28 bed. So it's always so nice to see people coming to give them, if they just needed an ice pack or some heat therapy, physio. Sometimes the children just want to be held. They just want someone to show that they love them. And the cognitive one, I love it best. Music therapy, art therapy. We are so appreciative of what the child life specialists do. We don't have them in Kehpca as a cadre, but we do have people like social workers and nurses who are trained in the aspects of child life specialists. So they try to also cover this gap. And we have a lot of volunteers coming in, you know, for the art therapy, the music, the play therapy, which is very nice for these children. And they are really able to go through their procedures and the painful things they have to go through with a positive outlook. And this actually even distracts them from their pain and their journey. Let's mention something small on spirituality. It's okay to explore the spirituality of these children and their families. Because remember, they're also trying to figure out the meaning of life. And the child is sick, has cancer. Some of them already, we've informed them that this one we will not be able to achieve cure. And so they're trying to find peace, they're trying to find purpose. And it's okay for families and these children to express how they feel and what they believe in. And children do understand death. From the age of 3 years and above, they have different perspectives, but there's an age-appropriate way of explaining impending death that is coming, and a child to be able to conceptualize that. It is okay to allow these conversations to happen because they are important, and they are important components of pediatric palliative care. Now, about hope. a lot of times we run away from having these conversations with children with cancer and their families because we are fearing we are going to take away their hope when we tell you about the poor prognosis that your child is having, and that now we have also come very late at diagnosis. Majority of our children, I said, are stage 4 and stage 3. Actually, right now, I can tell you in Kehpca National Hospital, I think in the last 1 or 2 years, I cannot remember the last time we ever saw a stage 1 child. Stage 2, very few. Majority stage 4. So you don't want to create false hope, but you're also not taking away the hope. What we are doing is to give parents the information, and a study was done, and I've shared this particular reference among my references for you to have a look at it, that showed that the parents who exhibit hopeful thinking, even when they are faced with a very bad situation and this child is going to die, initially the parents who are making hopeful statements, in the end, they are the ones that are more likely to give the limitations of care for their children not to suffer. And they don't have that unrealistic optimism. So let's not be afraid to talk to patients thinking that we are taking away their hope. No, hope is a good adaptive approach. We are not creating false hope, and we are not promising things that cannot happen, but we are just walking that journey with them. As they see their child every day, they learn to manage their levels of hope, then they now adjust, and depending on their spirituality and whatever they believe in, they even start telling you, you know, there's actually life after death. And now they start hoping for the other life after this child leaves. Depending on their religion, even in Islam, even the Hindi children we've taken care of, you find that those who are initially hopeful handle the situation better. So let's not be afraid. Let's individualize our goals of care for our children. Each one is different, even the ones from the same family. We've had the privilege in Kehpca to take care of children like twins several times from the same family with advanced cancer, but each child had to have an individualized plan and individualized goals of care where you discuss with the family and always weigh what you are going to achieve with all these interventions that we are trying to do. Yes, we are very happy when we can achieve cure, and that's what we are working day and night to see how we can increase survival. But when we cannot do it, it's good to accept reality and also bring the family to that space of what is the benefit versus the side effects of this intervention, and how is it going to impact? Are we prolonging suffering for this child, or are we really benefiting this particular child? So let's talk about end-of-life care. I'm trying to move a bit fast because I know we started a little bit late. So in terms of end-of-life care, it is something we need to face as palliative care practitioners, and us who work in the childhood cancer space. It is something we cannot run away from. Let us focus on keeping the child comfortable and also try to relieve the suffering for the family and the patient as they go through end of on the legal issues. The family dynamics are normally absolutely torn apart by childhood cancer. Like I said, the whole family is sick. Families get broken. It's normally very sad situations to be in. We are looking at the finances. Again, most of our patients are coming from economic backgrounds where they are not able to pay for most of the things. There are social and legal issues. But for us, our role as colleagues and as the team which is in this meeting today, and the gospel we have to continue preaching, is that ours is to understand, be there, anticipate the needs that are coming, and also prepare these families for the child's death. Actually, they normally come back and say thank you. You'll be surprised. It is very beneficial for these families to have someone or people that worked with them and prepared them for the death that is coming. So let's get comfortable talking about end-of-life care where it is inevitable, because again, it's not in our hands, matters of life and death. Now, there's something called an advanced care plan, and I know most of us have probably come across it. And this slide is just saying personal preferences and choices for care. We're still talking about end of life. And if you see these two children, one is saying, this is what matters to me. And the other one is saying, this is my voice, this is my way. We need to allow our children and their close families to express what they would want. And especially when a time reaches and the child cannot even speak, has deteriorated to that point of, yes, now we are at end of life. Before we get there, we need to, in advance, have prepared a plan, allow them to talk about it, to think through it. It's a process. This is not a one-stop event. It is a conversation we need to honestly have with them. As uncomfortable as it is, we need to bring ourselves to that space of being able to discuss this with them. Let's not be quick to give them, papers to sign, you have to sign this, you have to do that. No, let's not apply pressure on them, but let's encourage them to plan. And when we are doing end-of-life care, as we do preparation and support, over time, I've also come to realize that we need to prepare them that routines will change. Initially, I never used to know this. So it's also a learning process, even for me and for the colleagues that we work together, that they knew this child is, yes, he's sick with cancer, it's terminal, we are dying. But they used to know the child feeds like 3-4 times in a day. You have to tell them, in the coming few days, this child will be feeding maybe once or twice in a day, and it's going to come that the child cannot even feed. So the routines are going to change. And even tell them the breathing pattern is going to change. Sometimes you will hear some uncomfortable sounds coming out of the chest. The child will sound like they are gasping or they are not breathing well. Once you prepare them, when that moment comes, these families eventually actually come and tell us, thank you for having told us that this is likely to happen, than them just being shocked at what is going on with their child. Symptom management we've talked about. Location of death. Please, let's talk about these things. When it is clear that we are at end of life, do they want to die at home? Or do they want to die within the hospital, in the cancer treatment center, where also we are not now being able to offer any further curative interventions, or whatever they need can be offered elsewhere? Would they want to go to a hospice? These are conversations we can have. And right now, most of our children are dying in hospital, or they're even being brought back to hospital to die. And we accept them and we take care of them, but it shows the big gap and the need in pediatric palliative care, especially in childhood cancer, so that families can embrace more. A few of them now are accepting and they are dying at home, but majority are still being brought back to die in hospital. And you have to consider their cultural beliefs and the family environment and many other things. When death occurs, my friends, we have to prepare these families. What will they do when the death actually happens? Especially for those who choose to die, either away from hospital, because of the pronouncement. Pronouncing death is a legal issue. And of course, the child, they'll be anticipating the death. But when it actually happens, they have to call you, the palliative care practitioner or their primary doctor. Someone has to come, pronounce the death, and actually certify it. And then issues about, of course, postmortems. If it's a death you are prepared well, and the palliative team has worked with you all along, many of them don't ask for postmortems. I've encountered a few who still ask for the postmortems. Organ donation, again, this country is still making those policies, but the fact that our children have cancer does not mean they cannot donate organs, because it's not their whole body that has cancer. For some of them, it was just one organ that had that cancer, but it was maybe quite aggressive or quite advanced. So they can donate. I know Lions comes for Connie. Time, which can save the sight of many other people in the Lions Eye Hospital. But you cannot come to me, my child has just died, and you're now asking me whether we can do any organ donation. These are things, conversations that have to start way before. And of course, now bereavement support, we link them to support groups, we counsel them. Let's not forget the siblings of our children with cancer. The siblings feel very neglected because now all our attention and all our care is around the child who had the cancer. Let's see how to link them up. So let's think about these things. This slide just tells us we need to think, talk, and plan. So it's okay to think, yeah, I think this child and this family needs this and that. But we have to talk about it with the family and those closest to them, and then we make a plan. Because if we don't, when that time comes, it becomes very distressing, even for you as a healthcare worker or a palliative provider, even for us, even for that family. So let's think, then let's also talk about it, verbalize it, and then we plan. Finally, we are looking at quality of death. I know we've talked a lot about quality of life, which is really our focus. And we love life, but again, also when the child is dying, please let's give them a quality death and some dignity as they die. Being pain-free, let's communicate freely. We don't need to withhold information from these children or from their families. Age-appropriate communication. Children are curious and they'll ask us questions. Let's not lie to them. We find a kind way to be able to pass this information. Privacy. Please. This is not the time when now the whole school, because this child was in class 8 or was in class 6, everyone now wants to come and see the child as they are dying. No. The whole church, everybody wants to come. The whole village, everybody wants to come. We need to also set some boundaries that protect the dignity of a dying child to give them a quality death. We are respecting spirituality. Our chaplains are always there. Our imams and the sheikhs for the Muslims, even no matter what they believe, even cultural, the ones who believe in the African traditional religion, sometimes they even tell you they have a particular elder who needs to come and make some pronouncements on the patient, and they also want to have that person have some space with this dying child. It is okay, because at this point we have nothing to lose at this particular point, and it's good to respect them. Even some want a child to be baptized. We've had several children being baptized on their deathbed, even some getting their communion at that time, Holy Communion. It is okay, depending on what they believe in. Let us support the decisions that they make as a family, and also the emotional needs of the family. When the child dies, it's okay for that family to spend time with their dead child. It's fine. We are not prolonging, like now they'll spend a whole day with a dead child on the bed. But it's okay to allow them. Some want to speak to the dead child. Some want to tell the child several things. They want to just express their grief. It is okay to give them that privacy and that space to have a quality death and a dignified death. The rest of us and everyone else can mourn out there, but we've been able to give this child dignity at death as part of the pediatric palliative team and the bereavement support. So as we finish our conversation for today, the major gaps that we are facing, I talked about the disconnect we are having between focusing on just medical care instead of the holistic palliative care, addressing all the domains. And for us as healthcare workers, we are not adequately equipped, by the way, in pediatric palliative care. We need, even us, personally, I've had some training in pediatric palliative care, but I still feel very inadequate when it comes to some of these things, but we have to try. And we need to look for ways to keep educating, even forums like these ones. Let's talk to healthcare workers. Bring in your doctors, your clinical officers, your consultants, because you will think people know, but people do not know. We need to be equipped and we need to be trained. Even in terms of communication between ourselves as healthcare professionals and the patients. We run away. Our teams, people don't even want to be near when we are having these family conferences and we are having these maybe end of life conversations with families. Most of the very senior colleagues that we have don't even want to be near that place. They want to come back a few days later when that issue ended and maybe the child already rested and went. But if we were equipped as nurses, doctors, nutritionists, everyone equipped with palliative care training, especially for children, even if it's short courses, it will help us to provide better care for the children with cancer. Let us involve our patients in their care plan. In the ward round, we just there making plans, and you come and tell this child, so this is going to happen to you. You tell the family, so a decision was made to do this to you. It is good to also involve them in their care plans. And then the psychological, social, spiritual support may not be adequate everywhere. We realize those gaps and those challenges, and we continue trying to reach out to all these people to take part to be able to offer comprehensive care. Our referral mechanism is still weak, both for upward referral and downward referral. We are trying, but we can do better as a country to address these gaps. That there is a whole nice continuum and continuity of care. And even when now we are sending the child back to the community, we still know we have a palliative team there that can be able to care for our child. Of course, issues of poverty and inadequate resources is a recurrent challenge that we are facing in trying to offer adequate pediatric palliative care in our setting. So in summary, what have we said this evening? We've said that for childhood cancer, we need to have a high index of suspicion because these children present like any other common disease or any other common infection or injury. But if we have it at the back of our minds and keep raising awareness, we can easily suspect, because we said only early detection and early treatment, early referrals is what is going to improve the outcomes for our children. You know, they're not like us. They don't smoke, they don't drink, they are not sexually active. All those adult cancers we are talking about, and they give you a whole list of lifestyle issues. We can't say that about children, but early detection and early treatment, early interventions before the cancer has spread is what will improve outcomes. We've also agreed that palliative care begins at diagnosis and that it is multidisciplinary. Do not find yourself alone taking care of a child with cancer and feeling adequate. If you find yourself in that space, just know we are not doing the right thing. We need each other. Everyone has a role to play. Let's support the families and also the survivors. We've seen they also go through a lot and they need palliative care. And finally, even if we don't remember anything else, let's just ensure we have both quality of life for those ones who are living and also quality of death for the ones that are dying with us. Both ways. There's none that is more important than the other. And let's give our children dignity as they go through cancer treatment, which is really a difficult journey. And so there are heroes among us. I love this. I think I almost always end my childhood cancer presentations with this slide. I love it for many years now. There are heroes among us. It's not easy to go through childhood cancer. And the warriors are those ones that are still fighting and battling the cancer, and they're going through their treatments and keeping themselves strong. We have our survivors who have already gone through their treatments and now they are disease-free, but they are surviving with different effects, which we are also caring for them. And of course, we have the ones that have already been taken and those who left us. We need to always have that peace of mind that we did the best we could for them. And even at their point of death, we didn't abandon them, just being there for them. We make sure they died as heroes who went through a very difficult situation. They couldn't overcome it, but we gave them dignity. So that's the end of my presentation. We have shared some references and resources after that, which any of us can access, even to learn on pediatric palliative care, how to support these children. You can be able to read on your own, and also the references on most of the things I've spoken about. There's a whole list of references there when you have time. After that slide, there are many references that you can look at. So thank you very much, and thank you to Kehpca for the opportunity.
Thank you, Dr. Nzamu, for that informative presentation. I hope as the participants, we've learned a lot. I think we can proceed to questions or comments. If you have a question, you can raise your hand or type it in the chat box. If you raise your hand, you will be unmuted to ask your questions. Thank you. Let me start with the first question I've seen. Someone wants to know, Pamela wants to know how we can handle cases where the parents do not want the children to know that their life is limited. How do we handle that?
Thank you, Pamela. That's a very pertinent question and a very good one. The way I've seen it is that we just handle it by just consistently giving them the same message. And when they're coming in for family conferencing, a lot of times we encourage them not to come alone. And the team in KNH can confirm. When we do a family conference, we ask them, the parents, to come and also come with at least one or two others, somebody else who is not the direct parent. So we have this initial conversation together, and it's a continuous process. It's really a process, it's a journey. Sometimes this other person, either a very close friend or maybe just a member of the extended family, may be able to see and understand why it is so important. The child is the owner of the disease. We are not the ones carrying the disease at that time. And it is only fair for the child to get to know. And you know, children actually express their wishes. Let me tell you, when children know that their life is now limited, we've had children telling their parents of the place they want to visit, where they want to go, and particular people they want to see. And if you look at those children and how genuine they are, I had a patient, an 11-year-old child who was dying of osteogenic sarcoma that had already metastasized to the lungs. And at that point in time, the parents did not want the child to know, an 11-year-old who is already admitted in a children's cancer ward. And they know this is a children's cancer ward, and the children around them are also talking about cancer treatment. They all get chemo at the same time. They sort of have their own support group in a way. So this child already knew, but the parents did not want us to disclose. And so you continue that journey of disclosure and telling them how important it is. It is actually their uncle who eventually convinced them how important it is. When they agreed and we sat down to disclose, the child surprised all of us. He told us, I knew from the moment I entered this ward. And I've just been watching all of you trying to hide it from me, and watching how all of you are trying to struggle and behave like I shouldn't know. And yet I have all this information. This child had even written down in his book, a journal, his wish. He used to play the guitar. He was a musical child. He had a guitar, he had a violin. He had already written down who he wanted his guitar to go to, who he wanted his violin to go to, and that he did not want to die in hospital. He wanted to be at home. And so now it became a process of now the parents starting to feel guilty and feeling like, oh, we are sorry. And there was a lot of crying and apologizing. And, you know, we should have told you before. It was a quite unique case. But I'm trying to say, even when the parents are reluctant, you just take them through the journey slowly. It's a process. Involve somebody else that they trust. Oftentimes, children are more clever than what we think, and they already know. But eventually, I mean, if the family totally says, you know, we are not going to tell our child, just let them know. If the child is probably older than 4 or 5 years of age, they will have already found out, even before the family tells them. But we never force and we never push the parents. They'll eventually come and realize, oh, mtoto alikuwa ashajua, so you can just go ahead and have the disclosure session together with us. We just take them slowly, Pamela, but we try. Children have a lot to say, if only we would allow ourselves to talk to them about it. Thank you.
Thank you, Doc, for that answer. I'm not seeing any other question at the moment. Just a few comments. Raphael is saying, let us be miners of true and realistic hope. And Caroline A is telling you, great presentation. She's learned a lot on palliative, on children's palliative care. Someone wants to know, Simon K wants to know, for our colleagues who get attached to patients and become demoralized after losing the patient, and want an off for some days, how can they be helped? How do we support even the healthcare providers who have lost their pediatric patients to childhood cancer?
Yes, I've had that question when we get very demoralized and colleagues are very attached to the children. It is not easy, but we do have debriefing sessions. I'll speak for Kenyatta, and I would think also in MTRH, because we also work closely together with the team there, that we do have debriefing sessions for our staff, our nurses, and the people that are always closely in contact with these children, including ourselves, because yes, there are those days you really feel down and you really feel bad, and it's only human to feel so. What we do, we must encourage an outlet. There must be a way to let it out. And self-care is something we've really been emphasizing, especially for us who work in these kind of situations. And so other than now the actual debriefing, whereby now we are talking to the counselors and the counseling psychologists, it is okay for a member of staff to say today, especially after a death of a child who they felt very much attached to, that they need a day off or some hours off. In our unit, we have found a way to be able to cover for one another. The hospital policy in itself may not and does not offer that now you can just take a day off because you felt very emotionally disturbed by that situation. But within the unit, we have to caring for the carers among ourselves. So in-house arrangements are made when somebody really needs to take some time off. And we also do encourage therapy, even once every 3 to 4 months, like professional therapy. It's okay to cry. It's okay to go and let it out, re-energize, and then come back and continue caring for these children. The second thing we always keep telling our team members, death and life is never in our hands. So it is not up to you. It is not up to me. Life has its owner. And even people who have no spirituality or they don't believe in anything, they also know and they understand that life and death is not in our hands. The moment you internalize that, then no matter how bad you feel that day, the following morning you will wake up knowing it wasn't in my place to save this child. As long as your conscience is clear that you did your best with the resources that you had. So we try. It is not yet a perfect system, but yes, our staff do take some time off from time to time, depending on how low they feel, and we do debriefing. Yeah.
Thank you, Doc, for that answer. We have a lot of people congratulating you for the great presentation. And someone wants to know about breaking bad news to the family. How can we break bad news to the children and the family? But I've been informed that Kehpca will be having a webinar on breaking bad news next month. So I would request them to attend. Yes.
Okay. Okay.
I'm not seeing any raised hands, and I'm not seeing any other questions. I think we can end the session if everyone is comfortable. Thank you for your participation. Thank you. Oh, someone has raised her hand. Pamela has raised her hand. Emily, can you unmute Pamela? She's raised her hand.
Yes, you can unmute now, Pamela, in a position.
Thank you very much. There is a question I had put in the box, but I think it was not seen. While handling bereavement with children, we have two categories. That is the one who is dying of cancer and chronic illness, and the one who is grieving from a sudden loss of a parent. Kindly shed some light on how we can handle traumatized children whose parents die from accidents or any disasters.
Thank you, Pamela. That's a loaded question, and yes, it is true. Now, bereavement counseling. We do have counselors who do this bereavement counseling. I'm not so sure whether it is a specialty that somebody gets trained or if all our counselors are able to do bereavement counseling for a child who has lost a parent and the other way around. The way I've seen it happening where we are at is that these counselors come and they're able to walk this journey with the child. I've even seen their teams from counseling teams attend the funeral and have several sessions thereafter the burial of the parents. Now we're talking about the child who has lost a parent, and especially now the children that we are treating in our unit. I'll only speak about what I have encountered. We don't have a good bereavement support structure. Even those visits where they go and attend the funeral and schedule another like 1 or 2 visits thereafter are random. So Pamela, maybe you can allow me to interrogate that a bit more. Maybe tomorrow I can ask them exactly how they usually go about it and if there's a specific training or guidance on that. I really don't have an answer for you, but allow me to explore tomorrow with our counselors. Or if anyone else in the audience maybe has an experience, maybe can share with us if there's a system for it. Yeah.
Maybe I can just say that it seems to be something which is actually loaded the way you've said. And we as a team who are here, we need to look into it, because sometimes you realize that maybe a child has died in school, like recently the one who drowned in the swimming pool. Then the other children are there, they are grieved. How are they handled? How can we maybe look, because now we are taking care of children, how can we look into all these aspects so that as we come up with a package, we have some maybe SOPs on how this one can be done. It may not be one formula, but at least we need to have something structured which can guide maybe a counselor or how we handle them, because definitely a grieving, it affects them. Some it even affects their performances even in school.
Yeah. Yes, thank you so much for raising it. I think Kehpca and all of us who are here, including myself, we can explore that a bit further and see what we can do. Thank you, Pamela.
Okay, Doc, I think we can take the last question. Someone has just raised a question. Raphael G wants to know, what is your experience while handling other children in the ward who've lost a close friend, especially if they share the same diagnosis?
Yes, that is really usually a situation that we go through from time to time, particularly in the ward where they stay alone without parents. Where the children are a bit older, so we have that ward in Kehpca where they stay alone without parents. And they become like each other's keeper, and they know sisi ni wa leukemia, these are the ones for solid tumors, know each other, they sort of relate and they cohort themselves. So when a child dies in the ward, the first thing I have seen that we usually do is to have a group session for them. And there's a room we call the acute room, where we place the child who is dying. Most of our children in the ward refuse to enter that room. Even when they need oxygen and when they deteriorate, they try to fight it from their respective beds, because in their mind, they already know when you're taken to that room, sometimes you may not come out. But we are able to prepare them, especially when we have a child who is about to die or is going through that phase for end of life. Sometimes that morning when they're in the room where they normally take their breakfast, we let them know, so and so by name is really, really sick. And children are able to even come, have a look, visit, probably wave, say hi. When the child dies, they sort of grieve in a group. We've not had an individualized way of dealing with each of them and seeing how to support their grief when one goes. Then they have a session with the counselor, a group session. The mood is usually very low that day and the following day, but for some reason, children sort of bounce back, and by the second day, life is back to normal and everyone is back to their vibrant self. I've never thought about how each of these children is processing the loss of their colleague or their friend who they suffered the same diagnosis. It's also another area we could explore, but that's how we do it, like group therapy.
Thank you for answering that question, Doc. There's a last comment by Elizabeth K. She says, I wish to respond to that that children react to death according to age and stage of development, and there are resources that she would like to share to help us all to understand this when working with children. Yes, Elizabeth, thank you so much for that comment. I think you can link up with the Kehpca team so that they can be able to share with us those resources. Thank you so much.
Wow. Thank you, Elizabeth. I appreciate it.
So I think there are no more questions. I want to thank the audience for the participation and the questions. They were so informative and wonderful. And also a final thanks to Dr. Nzamu for that presentation. Thank you once again. I think we can have a good evening. Thank you everyone for your attendance.
Thank you and good night, everyone.
Good night, everyone.